Hello, ladies and gentlemen. I'm Dr. Jang from Sejong Cardiovascular Center. Today's my topic is management of dyslipidemia in high-risk patient. Definition of high-risk patient from 2019 ESG guideline are as follows. First, markedly elevated single risk factor such as more than 310 milligram per deciliter in total cholesterol or more than 190 milligram per deciliter in LDL cholesterol or more than 180 over 110 millimillimercury in blood pressure. Second, patient with familial hypercholesterolemia without other major risk factor. Third, patient with DM without target organ damage and with DM duration more than 10 years or have another risk factor. Fourth, moderate CKD. Fifth, a calculated score for 10-year risk of fatal coronary heart disease more than 5% and less than 10%. Today, I'm talking about dyslipidemia in hypertension and diabetes. This graph is the incidence of hypertension, DM, and dyslipidemia in Korean. Many hypertension patients have dyslipidemia. The concurrent treatment rate in hypertension patients was 53.8%. However, rate of patients who have more than LDL cholesterol more than 130 milligram per deciliter was 68.3% and more than LDL cholesterol 160 milligram per deciliter was 56.6%. This means that LDL cholesterol was not controlled in many hypertensive patients. In case of presence of several CVD risk factors, CVD risk is pretty increased despite of same category of systolic blood pressure. Coronary heart disease mortality rapidly increased by cholesterol level. This is ESC calculated CVD risk score diagram. Dark red is very high risk, red is high risk, yellow is intermediate risk, and green is low risk. It depends on several risk factors such as systolic blood pressure, total cholesterol level, age, sex, and smoker or non-smoker. It means that we should consider various risk factors to manage dyslipidemia. According to the ESG guideline for management of hypertension, we should control LDL cholesterol less than 70 milligram per deciliter or a reduction of more than 50% in very high risk hypertension patient, and we should control LDL cholesterol less than 100 milligram per deciliter or a reduction of more than 50% in high risk hypertension patient. And we should control the LDL cholesterol less than 150 milligram per deciliter in low and moderate risk hypertensive patient. This is a dyslipidemia clinical study in hypertensive patient, ASCOT LLA. Hypertensive patients who have more than 3 CV risk factors from 40 to 79 years, 19,342 people among patients who have fasting total cholesterol less than 6.5 millimole per liter assigned to atorvastatin 10 milligram group or placebo group. Primary endpoint is composite of non-fatal MI and fatal coronary heart disease, and the mean follow-up period was 3.3 years. Baseline blood pressure and the total cholesterol, LDL cholesterol are not different. Total cholesterol was decreased by more than 1.3 millimole per liter decreased than placebo group at 12 months and 1.1 millimole per liter decreased than placebo group at 3 years. Primary endpoint was decreased by 36% at atorvastatin group than placebo. This study is ASCOT legacy, and the primary endpoint is composite of all-cause mortality and cardiac death. Mean follow-up period was 15.7 years. There was no difference of baseline characteristics, including blood pressure and the number of cardiovascular risk factors. All-cause death was decreased by 8% at atorvastatin group, and cardiovascular death was decreased by 15%, and the coronary heart disease decreased by 22%. However, there was no difference between two groups in terms of stroke death. This study purpose is to assess the secondary prevention effect of ezetimibe classed by risk factor. Post-ACS patient 17,717 people was assigned two groups, ezetimibe simvastatin or placebo simvastatin. And primary endpoint is composite of death, MI, and CVA after 7 years follow-up. They used a novel risk indicator named TRS2P. It included heart failure, hypertension, aged more than 75 years, diabetes, prior stroke, prior CABG, peripheral artery disease, EGFR less than 60, smoking. 0 to 1 point as grouped low risk, and 2 point as grouped intermediate, and more than 3 point grouped high risk group. There was no difference in low and intermediate risk group. However, there was a significant difference in high risk group. As you can see, primary endpoint was decreased by 19% in ezetimibe and simvastatin group. Incidence of MI was decreased by 24% in ezetimibe simvastatin group, and the ischemic stroke was decreased by 32% in ezetimibe and simvastatin group. This study is EWTOPIA 75. It showed ASCVD prevention effect of ezetimibe in more than 75 years old patient. It compared between ezetimibe group and the placebo group. Primary endpoint is composite of sudden cardiac death, MI, coronary angioplasty, and stroke. Primary endpoint is decreased by 34% in ezetimibe group. And as you can see, LDL cholesterol was lower in ezetimibe group than control group. From now on, I'm talking about dyslipidemia management in DM patient. 34.9% of DM patients have hypercholesterolemia, and only 4 of 10 DM patients achieved target LDL cholesterol goal. Diabetic patients have LDL cholesterol more than 100 milligrams per deciliter is 86.4%, and diabetic patients have LDL cholesterol more than 160 milligrams per deciliter is 69.2%. So many diabetes patients was not controlled in terms of LDL cholesterol. This is the co-management rate of DM and dyslipidemia, and 1 of 3 people dyslipidemia have treated DM. This is the 2021 ADA guideline for primary prevention. 40 to 75 years old DM patients without ASCVD risk factor are recommended in intermediate intensity statin therapy. 20 to 39 years old DM patients with ASCVD risk factors are recommended statin therapy plus lifestyle modification. 50 to 70 years old DM patients with various risk factors are recommended high-intensity statin therapy. DM patients with 10 years ASCVD risk more than 20% are recommended maximal tolerable dose of statin with ezetimibe before more than 50% reduction of LDL cholesterol. For secondary prevention, DM patients with ASCVD are recommended high-intensity statin therapy independently of age. Despite of maximal dose of statin, DM patients with more than LDL cholesterol 70 mg per deciliter are recommended as DMARD or PCSK9 inhibitor. Older DM patients more than 75 years with the statin treatment are recommended consistently using statin. Older DM patients more than 75 years old should to use statin considering risk and benefit. This is the 2019 ESG guideline. Moderate risk type 2 DM patient should be controlled less than 100 mg per deciliter, and high risk type 2 DM patient should be controlled less than 70 mg per deciliter or LDL cholesterol reduction of at least 50%, and very high risk type 2 DM patient should be controlled 50 mg per deciliter or reduction of LDL cholesterol at least 50%. This is ESG guideline. Statin are recommended as the first choice lipid lowering treatment in patients with DM and high LDL cholesterol levels. If the target LDL cholesterol is not reached, combination therapy with ezetimibe is recommended. In patients at very high CV risk with persistent high LDL cholesterol, despite treatment with a maximal tolerated statin dose in combination with ezetimibe, or in patients with statin intolerance, a PCSK9 inhibitor is recommended. Lifestyle intervention and fibrate should be considered in patients with low HDL cholesterol and high triglyceride level. Intensification of statin therapy should be considered before the introduction of combination therapy. Statin should be considered in patients with type 1 DM at high CV risk, irrespective of baseline LDL cholesterol level. Statin may be considered in asymptomatic patient with type 1 DM beyond the age of 30 years. Statins are not recommended in women of childbearing potential. This is the Amadeus study for lipid lowering effect of type 2 DM Korean patient. Primary endpoint is target LDL cholesterol rich and lipid profile, LDL cholesterol particle size, hs-CRP, and adiponectin, and so on. This study showed the effective LDL cholesterol reduction in Korean DM patient and not influence hemoglobin A1C level. This is a hard study for primary prevention effect of atorvastatin in type 2 DM patient. This study analyzes the time to MACE for 28,839 type 2 DM patient with LDL cholesterol less than 4.14 millimole per liter and the fasting triglyceride 6.78 millimole per liter between two groups, placebo and atorvastatin 10 mg. There is no differences in baseline characteristics. It showed LDL cholesterol 40% reduction and total cholesterol 26% reduction, and then non-HDL cholesterol 36% reduction, and triglyceride 19% reduction, and the apolipoprotein B 23% reduction in atorvastatin group. Primary endpoint was decreased by 37% in atorvastatin group. Acute coronary syndrome was decreased by 36%. Coronary vascularization was decreased by 31%, and stroke was decreased by 48%, and the death from any cause was decreased by 27%. IMPROVE-IT study was for secondary prevention effect of ezetimibe, simvastatin in ACS patient. 18,144 patients stabilized post-ACS assigned two groups, ezetimibe, simvastatin, and the shipanstatin group. At 1 year, ezetimibe, simvastatin group showed a 24% decrease in LDL cholesterol level, and the primary endpoint was decreased by 6.4% in ezetimibe simvastatin group. And in subgroup analysis, statin plus ezetimibe have a more potent effect in DM patient. This is the DM patient. This is a no diabetes patient. This study is show the effect of ezetimibe to dyslipidemia patient in terms of cholesterol absorption and metabolism in Japanese. Ezetimibe improve fasting insulin, hemoglobin A1C, hsCRP, and adiponectin. It showed after treatment of ezetimibe, fasting insulin was decreased 12%, and hemoglobin A1C 30.4%, and hsCRP was decreased by 10.8%, and high molecular weight adiponectin is increased 13.4%. This study was effect of ezetimibe to visceral fat in metabolic syndrome. Ezetimibe decreased the fasting insulin and the HOMA-IR. This control group, fasting insulin level and HOMA-IR level. Ezetimibe group, fasting insulin level after follow-up level, and it showed a significant decrease in ezetimibe group. In conclusion, we should consider various factors to assess high CV risk, including age, blood pressure, smoking, and cholesterol level. In case of high-risk patient, more potent cholesterol treatment was needed. To achieve target global LDL cholesterol, high-intensity statin therapy may be needed. And in case of not controlled patient, concurrent use of ezetimibe or PCSK9 inhibitor are needed. The benefit of cholesterol reduction in high-risk patient are more bigger than low-risk patient. Thank you for your attention.